All right, good evening, everyone, and thank you for your time and your attention. Um, I'm Jarelys Hernandez, an infectious disease fellow physician from the University of South Florida, and I'll be talking about pancytopenia and profound neutropenia secondary or following a severe SARS CoV-2 infection with concern for bone marrow involvement. I have no disclosures to report, and these are my objectives. We are going to analyze a case of COVID-19 induced neutropenia with possible bone marrow involvement. We are going to discuss a differential diagnosis for the case presented, and we're going to compare and contrast to other similar cases. And we're going to evaluate the therapeutic use of granulocyte colony stimulating factor, or G-CSF, for COVID-19 induced neutropenia. So we're going to get started with the case, and this case was actually published in Open Forum Infectious Diseases as a novel ID case. So this is the case of a 44-year-old Mexican male with B-cell acute lymphocytic leukemia in remission, chronic Hep B infection, liver cirrhosis, and he presented to the ER on July 2020, complaining of cough and dyspnea for 2 days prior to arrival. He had completed hyper-CVAD chemotherapy, which consists of alternating cycles of cyclophosphamide, doxorubicin, vincristine, dexamethasone, methotrexate, and cytarabine. And this chemotherapy was followed by pump maintenance therapy, which consists of mercaptopurine, methotrexate, prednisone, and vincristine. So he presented 40 days after that treatment. His vital signs upon presentation: he had a fever of 101.8, and he was hypoxic with an oxygen saturation of 84% on Romer. His lab workup, we saw cytopenia with a white blood cell count of 1,390 cells per microliter, and thrombocytopenia with a platelet count of 42,000 cells per microliter. His absolute neutrophil count was normal, greater than 3,000, and he had elevated markers of inflammation. As I have here, CRP, D-dimer, and ferritin were elevated. So a diagnosis of COVID-19 was actually confirmed via PCR of a nasopharyngeal swab. So he actually had viral pneumonia that progressed to ARDS. For the sake of time, I'm not going to include the imaging here in my slides. But his ARDS and distributive shock required mechanical ventilation and the use of vasopressors. And they mentioned that he was admitted in July 2020 during the peak of the pandemic, and we had a statewide remdesivir shortage and inaccessibility to convalescent plasma therapy due to high demand. So our patient received empiric broad spectrum antibiotics. He received vancomycin, cefepime, and later piptazo specifically. He also received methylprednisolone 40 milligram that was tapered over 30 days. Due to the high dose steroids, he received prophylactic TMP-SMX and acyclovir due to his underlying malignancy. But he survived, and then on hospital day 13, he was extubated, and that's when things get more interesting, and that's why I'm here presenting this case today. So his hospital course was complicated by persistent fevers and mild hypoxia. And then on hospital day 17, he developed diarrhea and worsening pancytopenia. So to describe the diarrhea, it was watery, it was worse with each food intake. He will have his bowel movements, and he complained of cramps, as well. So GI was consulted, and they didn't have a clear answer for our question of why he was having diarrhea. They were thinking that probably his GI tract was getting used to receiving solids after receiving Q feeds for so long. Maybe it was some sort of dysautonomia that he was presenting with. We did a microbiology workup, of course, and everything was negative. C. diff antitoxin test was negative, GI pathogen panel and O&Ps were all negative. And Given his multiple comorbidities in his current presentation, we did extensive CT imaging of the thorax, abdomen, and pelvis, and everything was unrevealing. He finally received convalescent plasma on day 20 because he didn't develop antibodies despite surviving cytokine storm. But after his convalescent plasma, still his symptoms persisted. He was still having very high fevers, and he also developed severe neutropenia with an ANC of 500 cells, less than 500 cells per microliter, and that was on hospital day 37. So since hospital day 20 to hospital day 37, he was having this very high fevers every 2 to 4 days, sometimes lasting 1 or 2 days, with this watery diarrhea with some cramps, requiring supplemental oxygen, never more than 4 to 5 liters. Sometimes he was able to be off when he was at rest of supplemental oxygen. But we were treating him, we were providing supportive care, but we didn't really have an answer as to why he was having all this after surviving his cytokine storm. Because he was having high fevers in the context of severe neutropenia that eventually progressed to profound neutropenia, cefepime and micafungin were started empirically. We decided to do a bone marrow biopsy, and that happened in hospital day 40. And interestingly, his bone marrow was normal cell with no evidence of ALL recurrence, to our surprise, or hemophagocytosis. However, we did PCR for SARS CoV-2, and that was positive, and a CMV PCR was positive as well. That's from the bone marrow specimen. Now, EBV PCR and HSV PCR from the bone marrow specimen were negative. Also, from the bone marrow specimen, we did, or the pathologist did CMV immunohistochemistry that was negative, and we specifically asked for CMV-related cytopathic effects, and that was not seen by the pathologist. We also checked for parvovirus. We did a quant PCR that was negative. So this image was actually not included in the paper that was published, but for you guys to view that his bone marrow was actually normal cellular. And here, the second picture at the left, we have his bone marrow specimen that is actually negative for CMV immunohistochemistry. And for comparison, I included a positive photomicrograph. It's a different specimen. This is actually an antral biopsy, but for you guys to see the difference when it's positive. So also very interestingly, the day that our patient had the bone marrow aspirate, we also checked for CMV in the blood and a SARS-CoV-2 in the blood, and it was low-grade viremia for CMV, less than 200 copies. And he actually had 56 copies per ml of SARS-CoV-2. And Varicor was a reference lab that our TGH lab contacted to help us to run all these tests. We tried by contacting Varicor to see if we could isolate SARS-CoV-2 from blood and bone marrow, but that was unsuccessful. So I think it's important to kind of make a pause and kind of think about what we have, so that everything is clear as to what was our thought process. So we thought about HLH, or hemophagocytic lymphohistiocytosis. Given his underlying malignancy, he also was very febrile with splenomegaly, cytopenias, and elevated ferritin. But his triglycerides were normal. His bone marrow biopsy was inconsistent with the diagnosis. Also, we have to mention that he was already receiving steroids at the time. That is, kind of the management for HLH. So we didn't pursue further diagnostics. So we didn't do, or we didn't check for NK cell activity or interleukin-2 receptor. We also thought of CMV reactivation, but then again, his CMV immunohistochemistry was negative. We didn't see CMV cytopathic effects in the bone marrow biopsy. At some point, we started ganciclovir, but the patient didn't improve despite several days of therapy. It seemed like he was following like a natural course despite our interventions. And then eventually, just for completion, upon ANC recover, a colonoscopy was done, and it was normal for any CMV visceral involvement or ulcers. So I'm actually telling you guys that yes, he will improve, but the question is what actually happened and how that happened. So that will be explained shortly. So what is the diagnosis then? So syndromic diagnosis for our patient, we have a middle-aged Mexican male with B-cell ALL in remission and chronic hepatitis B infection and liver cirrhosis who survived SARS-CoV-2 cytokine storm that is demonstrating persistent systemic symptoms that include fevers, diarrhea, mild hypoxia, also with progressive pancytopenia and neutropenia that is now profound. And that is in the context of SARS-CoV-2 viremia with detection of SARS-CoV-2 RNA from the bone marrow specimen. And he has had multiple SARS-CoV-2 IgG tests that are negative. So our probable diagnosis is SARS-CoV-2 related pancytopenia and neutropenia with the information presented so far. So let's continue describing what happened with our patient. So that's the suggested diagnosis, and because he never developed antibodies and he was having still, he's having this fevers, diarrhea, we decided to administer to do a second transfusion of convalescent plasma, and that happened in hospital day 46. But again, his fevers, diarrhea, mild hypoxia, pancytopenia, neutropenia persisted. So on hospital day 53, we decided to do a 7-day course of G-CSF, and that was and after a very thorough discussion with hematology and hem-onc division, because there's a lot of we have controversial evidence that is suggesting that G-CSF in the context of COVID-19 can increase morbidity and mortality. So after a very detailed discussion, we decided to use that as an option, and I will explain why that happened, why we did that. So after receiving G-CSF, the patient defibrised and his ANC recovered 5 days later. Also, he's very improved with a reduction in SARS-CoV-2 viremia from 56 copies to 20 copies. And that happened between hospital day 46 to 60. Now, it's important to mention that probably this may represent a variation in the test rather than true improvement, but is worth mention. So our patient was actually discharged home on day 68 of hospitalization with improved yet unresolved pancytopenia and ongoing hypoxia requiring supplemental oxygen. Throughout the hospital course, he failed to seroconvert with negative anti-SARS-CoV-2 IgG testing on 7 separate instances, and the last was on hospital day 60. He was followed by hem-onc, and 28 days post-discharge labs were obtained, and his ANC was greater than 2,000. So here, this picture is showing, this graph is showing the ANC versus the hospital events in days. So you will see how from admission throughout the first 40 days or so, maybe 50 days, we're seeing this decline in ANC, and then upon administration of G-CSF, we see the improvement in his ANC, and then it remained pretty much within normal limits even after follow-up. So I made this chart comparing our patient with a patient with a case that was published by Isa and colleagues. So when we were trying to figure out what was going on with the patient, of course, we did some literature review, and we found this case, and we actually contacted the author to see what they did and how they managed the patient, to learn more from their experience. And I created this chart trying to compare and contrast. So this other patient, he was 53 years of age, male, also with underlying malignancy or heme malignancy. He had mantle cell lymphoma, but he presented on around the 3rd week in our patient. He presented after 2 days of symptom. And he had anosmia, decrease in taste, and he was having dyspnea as well. But he was pancytopenic, and SARS CoV was also isolated from the blood and the bone marrow aspirate. And I believe this is actually the first case of SARS-CoV-2 isolated from PCR positive from a bone marrow specimen, not isolated per culture positive PCR from bone marrow specimen. So we found it very interesting because it was exactly what we were seeing with our patient. That's why we decided to contact them. However, this patient was not neutropenic and he was not having diarrhea. This patient was managed with tocilizumab. He received 2 infusions and he received IVIG and convalescent plasma as well. And this patient also failed to develop SARS-CoV-2 IgG antibodies. But he improved, he defervesced just like our patient. And let's continue here. So our case could represent the second documented case of bone marrow disease and viremia due to COVID-19, and the first case of profound neutropenia directly related to COVID-19 prompting myeloid maturation arrest. That's the significance of our case. So there are different topics that I would like to discuss or bring to your attention. First, failure to seroconvert. Why that happened? So our patient neither developed anti-SARS-CoV-2 antibodies or improved despite surviving cytokine storm and receiving 2 transfusions of convalescent. Also important to mention that in a recent meta-analysis published in JAMA, convalescent plasma compared with control was not associated with improved survival or other positive clinical outcomes, but we still use it if benefits outweighed risk. So we believe that given our patients' impaired humoral immunity and probable development of myeloid maturation arrest due to SARS-CoV-2 infection, seroconversion was halted. And it's important to remember that seroconversion occurs in most patients by day 14. So it's also important to mention that, yes, our patient received antibiotics and other drugs that can cause cytopenias. He received vancomycin, piptazo, and entecavir for his chronic hep C. He received cefepime, TMP-SMX, acyclovir, Cipro. But it's also important to mention that we discontinued these agents, and despite multiple interventions, pancytopenia was not halted. And neutropenia progression was not halted either, and his syndrome did not improve at all. Also, it's important to mention that cancer patients with COVID-19 have a higher likelihood of death, with the highest mortality in the hematologic malignancy subgroup, and I think all of us are aware of that. In one meta-analysis, the pooled estimated death rate from 5 studies of 24 patients with cancer and COVID-19 was 20.83%. That is significant. And cancer patients are also more prone to COVID-19 infection than the average population due to cancer immunosuppression, anti-cancer drugs, radiotherapy, and surgical treatment. Also, I think it's important to mention that the pathophysiology of COVID-19 is not well elucidated. In addition to direct viral damage, uncontrolled inflammation may contribute to disease severity and high CRP, ferritin, and D-dimer levels like we saw in our patient. It's important to also mention that cytokine patterns are predictive of COVID-19 survival and mortality, and that's independent of demographics and comorbidities. And numerous reports suggest that individuals affected by SARS CoV and MERS-CoV have dysregulated cytokine production from both innate and adaptive immune cells, and that allows for progression to multi-organ dysfunction syndrome and ARDS. And SARS-CoV-2 appears to behave similarly. I mentioned before that authors commented there are some reports about that we need to be very cautious when we use G-CSF patients that are COVID-19 positive. And that is because there is an association with increased need for oxygen supplementation and an association with cytokine storm and even death. I found a case series where 3 patients who received G-CSF developed severe COVID-19 within 72 hours of administration. And it's also very interesting that I found another, a single center prospective CAR study that they were, that they actually used mavrilimumab, which is a G-CSF blocker. And treatment with this agent was associated with improved clinical outcomes compared with standard of care. And here we're talking about non-mechanically ventilated patients with systemic COVID-19 pneumonia and systemic hyperinflammation. So it seems like you probably want to block G-CSF receptor, not as much as stimulated, particularly in the context of acute illness. So that's what the evidence is suggesting. But our patient improved with G-CSF. So one key reason is the timing of G-CSF use. Our patient received G-CSF on illness day 56, several weeks after recovering from his cytokine storm. The time frame when G-CSF use could result in adverse events. So that's why, after a very thorough discussion, we decided to use this agent, and it was beneficial for the patient. So I found pancytopenia in the context of underlying heme malignancy, and maybe neutropenia. So that's not really common in the literature. I found 2 cases. I will just mention them really briefly. I found a case of a 61-year-old female with Waldenstrom macroglobulinemia, and she developed irreversible pancytopenia due to bone marrow aplasia after SARS CoV-2 infection. She presented with typical respiratory symptoms, fever, dyspnea, and then the pancytopenia that I mentioned. But she actually developed antibodies, and they did the SARS CoV-2 PCR from the bone marrow, and that was negative. But she unfortunately passed away from fatal invasive pulmonary fungal infection. And the other case is a 49-year-old male with follicular lymphoma that progressed or with transformed to diffuse large B cell that received chemotherapy and autologous hematopoietic stem cell transplant. And he actually presented with mild SARS-CoV-2 infection, but he developed thrombocytopenia. And it was thought to be due to ITP prompted by COVID-19. So he received IVG, but then eventually he developed pancytopenia and neutropenia. But this patient in particular, he self-resolved, like his cytopenias resolved, pretty much matching the duration of infection. Very interesting. And his bone marrow biopsy showed non-specific reactive changes. And for this patient as well, just like the prior case, the bone marrow specimen was checked for SARS-CoV-2 PCR, and it was negative. So here are my conclusions. Patients with hematologic malignancies have an elevated risk of severe and or atypical forms of COVID-19. Our patient's syndromic COVID-19 sequelae appear to follow a natural course despite adding and discontinuing antimicrobials for therapy prophylaxis. In our case, CMV appeared to be an innocent bystander, and we didn't see any immediate clinical benefit from convalescent plasma transfusion. And the use of G-CSF for neutropenia management in COVID-19 patients seems to be a safe therapeutic alternative after the cytokine storm has resolved. SARS-CoV-2 PCR, a blood and bone marrow specimen, should be considered for diagnostic purposes if pancytopenia or neutropenia evolve in COVID-19 patients, especially in the immunocompromised due to a heme process or malignancy. And then again, this case highlights the importance of understanding the temporal relationship between COVID-19 and neutropenia as treatment approaches that might be on opposite ends of the spectrum, from immune deactivation to immune reactivation. These are some of my references. And I would like to thank you all for your attention and for your time, and I'm open for questions.